nevite, cyst, corn, keloid, adnexal tumors which may be benign or malignant lesions. The first and foremost is the punch excision. Punch excision is nothing but an extension of punch biopsy technique which we have learned during post-graduation. It is done for small lesions which are up to 5 mm in size, circular lesions. For example, melanocytic nevi, acquired melanocytic nevi which are round, circular, and the corns and small cystic and benign adnexal tumors. To do punch excision, first we have to choose the appropriate size of the punch. First we have to measure the size of the lesion with the help of a scale, and the same size of punch has to be taken. To do the procedure, first you have to anesthetize the lesion. Here you can see on the left hand side, the melanocytic nevi is being excised. Take the appropriate size punch and keep it perpendicular to the lesion. Stretch the skin and with circular rotatory movement, gently go into the skin. Once you reach the resistance, that is the site where we have to stop, because loss of resistance indicate that we have reached the subcutaneous plane. So after that, you remove the punch and hold the tissue that has to be excised with the forceps, and with the help of blade, you can cut the lesion. The level should be at the subdermal plexus. And after that, it is closed with the simple sutures. Here you can see on the left hand side, it is being closed. After punch excision, you can wait for 2 minutes so that the defect aligns itself along the RSTL, and then you can suture it along the RSTL. Here is a planning for elliptical excision. The center of the ellipse is the lesion. Around the lesion, a perfect ellipse is planned in such a way that the length and breadth are in the ratio of 1:3. Here you can see the breadth of the lesion is x and the length should be 3x. So that results in a perfect linear scar. If this ratio is not maintained, it can result in doggy or ugly scars. So here is the two neurofibroma lesions which are located adjacent to each other. What we have done here is the two adjacent neurofibromas we have fitted into two in a single ellipse so that they are at the center of the ellipse, and we have maintained a ratio of 1:3. Here you can see after marking, the lesions is being excised with the help of a scalpel. After excising, make sure that we close the lesion in two layers. One is dermal layer and followed by the epidermal layer. The next common condition that we encounter is the cyst. Here is an inclusion cyst which is just beneath the eyebrow. What we have planned here is a single incision that is placed just below the eyebrows, and the cyst has been excised so that a linear scar is formed just below the eyebrows, which is invisible just below the eyebrows. If punctum is seen, you can put an elliptical incision. If punctum is not seen, you can just put a simple incision and then remove the cyst. Whenever you are removing the cyst, make sure that the whole content of the cyst along with the cyst wall is completely removed. Otherwise, it can result in recurrence. Another common condition is lipoma. Many people that present with multiple lipomatosis, which are though asymptomatic, sometimes because of the cosmetic appearance, they seek excision. What we can do is, instead of putting a long incision, we try to extrude through a narrow incision, that is called as narrow hole extrusion technique, or NHET in short. Here around 6 mm of incision is put. With the help of a 11 number blade, you can just put a stab incision, or you can use a punch of 6 mm. Reach the subcutaneous plane. We know lipoma is a non-capsulated tumor. Once you reach the plane, release the lipoma lesions and put pressure from on either side so that the lipoma just extrudes. Easily it can be extruded and it can be closed in two layers. Neurofibroma is another dermal tumor which presents with multiple nodules on the skin. So patient sometimes seeks excision because of the cosmetic disfigurement, where we have to do simple excision. Either we can put a single incision or you can put an ellipse so that the whole neurofibroma can be excised. Another condition that is commonly presenting to dermatologists is keloid. And the main problem with the keloid is the recurrence. Whatever may be the treatment of option, keloid is general rule in keloid. And the only keloid that is amicable for surgery is the earlobe keloid. And excision should be performed gently, atraumatically, so that the borders of the wound can be approximated without any tension. The rules that has to be followed during keloid excisions are 5 A's and 1 B, that is asepsis. We have to maintain complete asepsis without any infection. Atraumatic techniques means you have to use sharp instruments and less traumatizing forceps so that surgical trauma stimulate the scar formation again. And there shouldn't be any raw surface, because raw surface delays wound healing. Again, that results in recurrence of the lesion. And there should be minimal or no tension, so that the tension also again results in recurrence. And there should be accurate approximation of the wound margin. And there should be complete bleeding control before closing the wound. So here is a dumbbell keloid which has been excised. What we have to follow in keloid excision is intrakeloidal excision. That means your excision should not extend beyond the keloid margin, so that if you create a new wound, again that results in a keloid excision. So here simple elliptical incision, but make sure that your incisions are within the keloidal tissue and it is closed. For small lesions, you can just do intrakeloidal excision and close it. For larger lesions, we have to go for fillet flap. In fillet flap, what we do is the normal skin over the keloid is used as a flap so that it can be close the defect. So here it is called as keloid fillet flap. So here you can see here, in this image you can see the keloid here it is debulked and the top layer of the keloid it is used as a flap, and the flap is retained here and it is closed blank, so that cosmetic appearance is very good and also there is absolutely no tension here. The advantage of fillet flap is there is complete debulking can be achieved within a single sitting, and there is no separate donor site that is required because the keloid skin itself acts as a flap, and because skin has already been stretched there will be no tension and it is cosmetically more acceptable. So here is an adnexal tumor which was between the eyebrows. So what we have planned is a simple elliptical excision and it is closed here. Simple excision, we'll move on to flap. Flap is nothing but a unit of tissue that is transferred from one side to another while it's maintaining its own blood supply. When do you consider flap surgeries? Defects are small, either we can go for punch excision or elliptical excision. If the defects are large, then we have to consider the flap surgeries. Here you can see the defect is so large that it's very difficult to close for simple excision. Sometimes the defect may be very small, but it may be located in such a situation that if you attempt primary closure, that can result in distortion of the anatomical structure. Here the low lesion is small, it is between the eyebrows and hairline. Primary excision has resulted in distortion of the eyebrow. Coming to the basics of flap, it includes primary defect, secondary defect, pedicle and pivotal. Before going into the flap surgery, you should be familiar with these terms. Primary defect is the one which results after excision of the lesion. Here you can see, here is a primary lesion that has been excised. So this is called as a primary defect. And once you close the primary defect, here we have raised a flap from the adjacent skin. So the new defect that is created is called the secondary defect. And now after moving the flap, here is a point that gets the maximum tension, that is called the pivotal point. And the other important thing is the pedicle. This whole thing is called the pedicle because through the pedicle, the vascular or blood supply of the flap takes place. So depending on the methods of transfer, they are classified into local and distant flaps. So under local flaps, depending on the direction of the movement of the flap, they are classified into rotational flap, advancement flap and transposition flap. And distant flap includes pedicle and free flap that usually done by the plastic surgeons. So first and foremost is the rotation flap. You can see here, this is the defect. So here the defect is converted into a triangular shape and adjacent to the defect, a flap is raised. Here what we do is, this is the flap that is being raised. We have to maintain certain ratios. If X is the size of the defect, your arc should be around 4x and the pedicle width, here the pedicle width should be around 3 to 4 times the defect. Here, after raising the flap from the adjacent area, you can see here it is rotated into the defect and it is closed. That's why it is called as rotation flap. How do you plan a rotational flap is? Rotational flap is pivoted around a fixed point, and make sure that when you're rotating the flap, its angle should not be less than or more than 30 degrees. That otherwise it will result in thick necrosis, and the arc of incision should be 4 times the defect and the radius of the circle should be 2 to 3 times the defect. Rotational flaps are usually done for small circular defects on the scalp or cheek defects which are 3 to 4 cm in diameter and defects less than 2 cm over the lateral forehead of the temple area. So here is a porocarcinoma of the scalp. Here we planned a rotation flap. Here is a primary lesion. A circular defect has been formed here and around that a flap has been planned here. Primary defect, and this is how it looks after closing the defect with the help of a flap. So this is another rotation flap which was there on it was a BCC case present on the cheek. Here we raised a flap from the adjacent area and rotated into the tissue. So here is a BCC that was presented on the side of the cheek. Here, after excising the primary defect, we raised a flap from the adjacent area so that the flap is rotated into the defect. The modification of rotation technique is the OZ reconstruction. In single rotation technique, if the defect is small, we can rotate the skin from the one adjacent area. If the defect is very big, then we have to rotate the tissue from both the side of the defect. So that is when we create a OZ reconstruction. Here you can see a primary defect which is large, and on either side of the primary defect you can create two flaps on the opposite side, and two flaps are rotated into the defect so that it closes like a Z. You can see here the O defect converted into a Z defect. So this was a BCC.